So we're going to go ahead and get started with gaining some new knowledge, helpful knowledge about cyclic vomiting syndrome. So I've heard that the speculation was 60% of the people identified with CVS, with JDVS, are suffering from CVS. And this morning I saw the statistic 19%, so we don't know. Don't have an epidemiology study for that. But when I read about it on the Facebook page and see the suffering that's going on and see pictures of, it could be Molly on Facebook, it reminds me of the agony of CVS. So 32 years ago, I was in a small room at the Medical College of Wisconsin with 5 people, 5 family units. Dr. David Fleischer, who's known as the grandfather of cyclic vomiting syndrome, and the person that you're going to listen to today, Dr. B. Lee, was one of the other physician who has steadily, with an enormous amount of knowledge, dogged determination, personal commitment to educating the world about cyclic vomiting syndrome. And without education, it can just devastate families. So Dr. Lee is a pediatric gastroenterologist. At that stage of his career, I think I have this right, he was ending residency at that point at the University in Columbus, Ohio. Faculty at that point. But had done a paper about cyclic vomiting. So when we were trying to find resources to help these 5 family units, which later has become Cyclic Vomiting Syndrome Association, Dr. Lee came. He was admittedly hesitant to come and participate. Evidently he had some background with what he called zealots from parents, families, about the power of the families that had gone astray as far as being able to be effective to form groups and associations. JDVS is not one of those. Turns out CVSA was not one of those. So he joined, he's here, and he's the guru of CVS internationally. Dr. Lee.
Good afternoon. Can you hear me in the back? Yes, okay. And it's been a long day, and I really thank you for coming, looking for answers, and hanging in there. I want to thank Cara and I guess the other 3 musketeers for inviting me to attend. And actually, Kathleen is responsible for me being here in person because I'm usually in Canada at this time of year. And I want to tell you how impressed I am with the rapid progress of your organization. So in CVS, it only took 111 years from the first description to the formation of CVSA, and this has been done an amazing job in 6 years. So you have just heard from, I would consider, sophisticated software engineers who deal with complicated genetic code, and now you're going to hear from a lowly plumber, a gastroenterologist. So hopefully maybe it'll be more understandable. Actually, I'm a neurogastroenterologist, and that deals with the gut-brain connection. And it's a kind of a growing subdivision of pediatric gastroenterology. And obviously the hottest area is the microbiome, but we still know very little. And finally, before I start, I wanted to ask you if you wouldn't mind to raise your hands of the families that are affected by cyclic vomiting syndrome, so I get a sense. Okay, plenty. So thank you. So you could see that I'm from the frozen tundra up there because of the code. I spent most of my career in Wisconsin. And for those of you who don't know what emeritus means, it means I'm old and over the hill. Okay. So this gives you an idea of 32 years of progress due to CVSA, and really Kathleen started the ball rolling. And so we established the name of it, its prevalence, and even a diagnostic code. We've held 14 biannual conferences like yours. We have multidisciplinary programs. I started one at Lurie Children's, a second at Children's of Wisconsin, carried on by my mentee, Katya Corrento, and an adult mentee, Thangam Venkatesan, has the only adult dedicated program at Ohio State University. We held scientific symposium in 98, 94, and 22, very, very multidisciplinary, trying to understand it from the migraine aspect, the brain aspect, the gut aspect, and finally we do have guidelines starting in 2008, an update in 2025, and adult guidelines in 2019. So we have made some progress, even though it's still quite mysterious. So this gives you an idea of, before that, 92, it was a flat line, meaning no literature shown there. So it would be 0 to 1 over the last 100 years. And so as a result of this interest, the formation of CVSA, the symposium, you can see a rise in there. And in the dark line is a related disorder called cannabinoid hyperemesis syndrome. Have any of you heard of that? It's related to overuse of marijuana. And it's, for example, growing in Colorado, which was the first state that legalized recreational and leads to a cyclic vomiting syndrome type of disease. And here is just an example of our latest symposium. The proceedings just came out, and you can see very multidisciplinary, tackled the autonomic nervous system, migraine treatment, CGRP, endocannabinoids, which involves obviously marijuana, but also your endogenous system for processing and reducing stress, which involves your own cannabinoids. CD15, growth differentiating factor 15, which is a new trigger that correlates with vomiting up in the brain, and then neuromodulation, which is some exciting work of my mentee, Katya. Well, this is Molly's story in a nutshell. Molly, can you raise your hand? Okay. And you can see her baby picture, and you can see Jasper, yes. Jasper, yes. And starting at age 1.5, she had undiagnosed, hospitalized vomiting episodes, meaning 100% of the time in the hospital every 6 to 8 weeks. And eventually it evolved into getting a central line, which allowed her to do the episodes at home, which is one option, but it requires a line. And medications that didn't work, you'll hear more about these during the presentation: cyproheptadine, propranolol topiramate, which led to a kidney stone, reactions to ondansetron help, Pyridol, and sumatriptan. And finally was diagnosed at the age of 12 after Kathleen's long journey looking for answers by Dr. David Flesher, whose name you heard. And what did work was amitriptyline, CoQ10, mitochondrial supplement, and escitalopram. And finally, she was diagnosed by one of my collaborators, Dr. Rick Bowles, at age 42 with JDVS. And an incredible journey for both Molly and Kathleen. And finally, she's gradually transitioned to 1-day spells every 2 to 3 months that are not cyclic vomiting.
I don't do it anymore. I just have those days I shut down
Yeah.
but I don't.
You don't vomit, but you have a lot of those same inside feelings that you used to have, the nausea, listlessness, and so forth. I think you call them dysautonomia days. Yeah. So, and here you are today. So we all have nicknames. So my nickname is the Exalted Emperor of Emesis, which is vomiting. And I know this is the only slide you'll remember, but you can address me as the Emperor. I do respond to that. So today I'm going to discuss the clinical features, use the guideline that just got published in April to give you the latest treatment. It's actually different than I thought it would be. Talk about the overlap of CVS in JDVS, and talk about recognizing comorbidities, specifically GERD and constipation. And finally, some clinical tips and maybe a protocol and advice on dealing with emergency rooms, which are very, very troublesome for CVS patients. Well, this is the guidelines that's published, and I'm going to give you the reference at the very end that you can take a picture of. And we also use some new evidence on the phenotype, meaning we took a series and compared them to a simultaneous series of kids that presented to the emergency room and to the clinic to say what features differentiate the vomiting of CVS. And this is what it looks like. And sophisticated statistics to try to differentiate what really separated them out. So 4 to 10 episodes over 12 months. So for example, GE reflux would be much more common than 10. More than 2 hours of duration of vomiting. Multiple episodes of vomiting per hour, and at the peak, our first paper published, at the peak it was every 10 minutes, 6 times an hour at the worst. Almost nothing makes you vomit like that. Stereotypical episodes, so parents say it's the same thing happening, start about the same time of day, goes the same number of hours, and they look completely shut down the same way. Nobody else is sick. Sensitivity to light and excess sweating, and episodes about at least a week apart. They can be months apart, but at least a week. And one of the surprising things is we had reported before about 12% have nausea in between, but 39% still had some GI symptoms in between, and I'm going to review those. We call them comorbid symptoms. So this is what it looks like, and hopefully these will become actually the Rome 5 criteria, which are used. Stereotypical episodes between 4 and 10, lasting 2 hours to 7 days, 1 week apart, return to baseline, associated with those same symptoms, sweatiness, light sensitivity, which we've heard about, and other symptoms may be in between, because before we said they have to be well in between, and that's clearly not the case. So the key clinical questions your clinician should be asking when you come in: have there been similar episodes repeatedly when no one else is ill? Unfortunately, because everybody approaches as an acute illness, they don't ask that question and they don't see the pattern, and it's often missed for months. In our first paper, the average time to diagnosis was 15 months. Well, how common is CVS? Well, here's some other C diseases. Celiac, you've heard about, gluten sensitivity, Crohn's disease increasing. But look, CVS is more prevalent or more common, and the incidence is much the same. And in adults, it's also found in 2%. This is totally new. 30 years ago, we had no idea it occurred in adults. We thought it was just pediatrics. Well, are all cyclic? And the answer is a simple no. There is a classic pattern, and I define cyclic as within 1 week of predictability, but about 50% are sporadic, and these tend to have more triggers, and you've heard about them, and I'll go through them again, including excitement. We have one cyclic group that has very long cycles, about 2 months, almost on a dime, meaning the parents can bring in a calendar, it's within 1 or 2 days, and we don't know what the rhythm is or calendar that can do that. That's a particularly difficult one to treat. And we have some that have kind of mini episodes within 24 hours. So obviously the height is a number of vomits. They get better by the end of the day, start in the middle of the night, do it again, and then none. And then the last pattern is coalescent, meaning that there are symptoms in between, and we heard that it could be up to 40%, which is much higher than we ever anticipated. Well, what are the key symptoms? You can see the listlessness and pallor, and to me, those are very, very striking, because I remember one of my fellows coming in going to see the patient coming out to me immediately saying, she looks like she's in coma. And I said, she's in a CVS episode. He said, oh, he didn't realize how devastating it can be. The paleness can look like they're in shock. The nausea, tummy pain, lack of appetite, dry heaving, and you'll hear again and again a relationship to migraine headaches. But you can see less than half actually have headaches, and that will increase with age. I will show you some natural history. Now, some of the unique symptoms include retching while the stomach is empty. So the guttural deep retching on the same frequency could be every 10 minutes, and there's nothing there. That has told us very clearly this is a brain disorder, it's not a gut disorder. Guzzling and vomiting was thought to be a psychiatric sign, but indeed it's usually the person trying to dilute the bile, which is extremely bitter, and then get it out. It's not psychiatric. And hot water bathing, I don't know if any of you have used that, okay? And that is an interesting one because that was thought to be diagnostic of the use of cannabis, but it is not. So here are some interesting clues. 74% of the cannabinoid hyperemesis syndrome use hot water hydrotherapy. 48% of CVS without marijuana use cannabis, and kids also use, without cannabis, use the hot water bathing, and children do too. And so it's clearly not diagnostic. And unfortunately, if you go into an emergency room and say, well, we tried marijuana once, they will label you as a cannabis abuser because they automatically associate it with CHS, and so will misdiagnose one. And this has happened especially to adults. Now, I will tell you, had one very enterprising family. Of course, every time they depleted the water heater in about an hour and a half, they checked into a hotel, and they went on and on. This is a very clever response, and it worked. So, in fact, look, hot water bathing, and it can be very hot, and the child not even be able to tolerate the same temperature when they're well, works in 5 to 10 minutes. And when you take it away, the vomiting, nausea and vomiting comes back in 10 to 30. And it's a very interesting story and why it works, which I won't go into. Well, also our picture of the disease has changed dramatically in the last 20 years. We thought it was primarily an episodic vomiting disorder. The kids are well in between, but a whole different picture has emerged. And I call it a tenacious problem because of all these tentacles. Anxiety and depression. If you look at school-age kids, anxiety is 59%. Limited stamina, I think we've heard about that. Some of this sounds very familiar. Decreased exercise tolerance, the kids have to stop, can play sports, but they have to stop frequently. Daily nausea may be closer to 39 to 40%. Sleep disturbance, onset, maintenance. Postural orthostatic tachycardia. When they stand up, they get dizzy. This is more a teenage problem. Constipation, IBS, 40%. Sounds very familiar in complex regional pain syndrome. 3 of these per child on the average. So when they're well, they're not well. Are there triggers? And I think all of you are familiar with this. Psychological triggers are the most common, and it's usually in children more positive than negative, even in adults as well. Excitement, birthdays, holidays, vacations, trips, family reunions, infections, nonspecific, lack of sleep after a intense weekend, like maybe even this weekend, dietary triggers, cheese, chocolate, MSG. Interestingly, in double-blind studies, they don't hold up, but if parents report it, we avoid those. Menses in postmenarchal girls, and weather changes, cold fronts coming in. He had one father who would watch the weather, and he knew when he would get a migraine, the child would not watch the TV, and he he would fire off in CVS in tandem with his father's migraine headache. So why is CVS so disabling? And for those of you who have challenges with it, obviously intense vomiting that's often misdiagnosed as stomach flu, psychological, food poisoning, and it's worse than stomach flu. Repeat ER visits, hospitalizations, and they're often unpredictable and just disruptive. And symptoms in between. Again, a change in our whole concept of this disorder with abdominal pain, chronic fatigue, headache, nausea, and then comorbid conditions, the top of the list being anxiety. And the anxiety burden is troublesome in more than one way. One is by anticipation, so it can trigger off another episode because the same trigger is present, and then they start worrying about it, simply like those who get into anticipatory nausea and vomiting with chemotherapy. And it can worsen or prolong episodes and contribute to disability as well. Well, how does CVS affect your child's quality of life? And this is the total score is on the left, and then the different domains, physical, emotional, social, and you can see CVS is the lowest from normals to organic GI disease, including Crohn's and irritable bowel syndrome, another disorder of gut-brain interaction, and significant with both healthy controls and irritable bowel syndrome. So it is more challenging. But more interesting is the quality of life correlates not with the disease severity, but actually with anxiety and coping. And it argues so strongly for the role of counseling and psychological therapy. Okay, we'll see you, Molly. And so I will say that in my multidisciplinary program, I always had a psychologist with me to see the patients together. So now when we look at CVS, I don't see one disorder, I see multiple. And part of the reason, as you saw, I've seen so many of these kids, almost 1,300, from really almost all states and 5 continents. Many are migraine related, and we're not even sure what a migraine is. There's one variant associated with high blood pressure. It's the most difficult, it's the longest, the worst, hardest to treat episodes, and they have evidence that their whole stress axis with ACTH, cortisol, catecholamines, adrenaline, ADH are elevated. We have ones with developmental delay that Rick Bowles has called CVS, plus with maybe mitochondrial associations, dysfunction, and now, of course, Janssen-DeVries has to be thrown in the mix. We have ones that start with periods that we call catamenial CVS. They're parallel to menstrual migraine. And this long cycle group I talked about that's difficult to treat, mitochondrial dysfunction, he would say it's much higher based on kind of more of the symptom complex. And in our series, those with a proven complex 1 deficiency lower, partial orthostatic tachycardia, dizziness, more of a teenage problem, and finally the cannabis. So in today, we might actually have these subtypes eventually, and maybe we'll have some gene markers, maybe some other profiles that will help us put them in a pot that may allow us to treat and individualize the treatment into a migraine subgroup. But you can see some of these overlap because the numbers add up to more than 100. The one with the very activated HPA axis, the stress axis, the menses, the mitochondrial, and also the cannabis-triggered variety, and which also occurs in teenagers. So more of the new series have described cannabis-induced hyperemesis in teenagers because of the amount of recreational use that's increasing as well. Well, what happens as children age? And you can see The classic progression is from CVS in the younger to abdominal migraine, age onset of 7, and then migraine headache starting at 8 with a median of 12. But some can go in different directions. Some can have more than one, and I've had few that have all three at the same time. And actually, the treatment is slightly different. And we have estimated that 75% will develop migraine headaches by the age of 18. So most do outgrow CVS, but some continue into adulthood, and we don't know how to predict which ones or how many, but eventually we'll have the answers. Well, the other part of what can happen to these children is a new paper by our group that showed that 40% develop autonomic dysfunction at a mean age of 15, and there are more girls than boys. So what this means, I would say one of the prominent symptoms would be nausea, the nausea in between, some of that dizziness when they stand up, and all the subgroups are whether they had just symptoms, they had tilt table testing, and whatever. But it also turns out another pathway, unfortunately, does not lead to complete wellness, but they can also develop a dysautonomia. Well, what are mechanisms involved in CVS? I'm not going to go into much detail, but just give you a sense of what we are thinking in 2025. Clearly, the migraine connection, it's been actually identified in 1898, and so I wrote a paper, I think, in 94, but actually it was a recycling of an old idea when I looked more in detail at the literature. We know the stress axis is very, very involved, and we saw that from the Sato subtype, where the whole stress axis is just maxed out. But the endocannabinoid system, which helps attenuate and modulate and downregulate stress, is also involved. And Dr. Venkatesan has shown that there's some polymorphisms that make you more susceptible to develop CVS, and could explain why this cannabis or THC, marijuana, can trigger people into CVS. The autonomic nervous system is clearly involved, and we knew way back that sympathetic tone, the fight or flight reaction, was upregulated, but it turns out to be more complicated, and the newer evidence shows that there is decreased parasympathetic vagal calming of the sympathetic system. That's the more underlying defect. And finally, the mitochondrial, and the way that Rick Bowles tends to think of this based on some whole genome screening is that many of the SNPs that are identified and increased in CVS are those that affect cellular energy and cation transport. So both of those could give you a situation where your cells, especially your neurons, are hyperexcitable, and then when a threshold is reached because of stress, lack of sleep, excitement, you develop this kind of autonomic storm. So in kind of a summary of the syndrome, it's clearly severe, disabling, and results in a lot of medical costs. And the child is not well when well, and I'm hearing the parallels. CVS can morph over time, not only to migraines, but autonomic dysfunction, and CVS remains underdiagnosed, misdiagnosed, and completely misunderstood by the medical profession even today. Some recommendations on treatment, and these are some broad strokes. This is from David Flesher, kind of the 4 phases: inter-episodic, meaning well, the prodrome, when there's a warning phase, and then the vomiting phase, the spikes, and then recovery. And looked at it, you can see the goal during the well phase is prevention, lifestyle measures, sometimes preventative medication. When there is a warning phase, and I was hearing some of that this morning, is a time when you can intervene, because there are two approaches particularly geared towards a prodrome. And then during the emetic phase, you're just trying to calm things down. Usually you can't stop it if it's failed. And then the last is just helping recovery with nutrition. So management principles: lifestyle change, fluids, calories, exercise, sleep, all good lifestyle. These are really borrowed from the migraine literature. Preventative anti-migraines, anticonvulsants, mitochondrial supplements, and you're going to hear about neuromodulation, which the center of which is in Milwaukee at our center. Abortive triptans, of course, borrowed from migraines, can work in about 50%. Aprepitant is a new one. And rescue, oftentimes you are just trying to hold things together. But interestingly, deep sleep, and I heard about sedation, we've sometimes woken kids up when they've been sedated for an MRI, for endoscopy, and then the episode's over when they recover. Interesting. And then, of course, psychological. I can't emphasize that. Well, this is from David Flesher. Look at this little graph of frequency of episodes per year. On the left, before when they came into the clinic, and after consultation, education, and a plan, no medication, the episodes fell in 70%. So having a diagnosis, education, can relieve family stress and actually help the situation, the good doctor effect. Sleep, of course, is important. Scheduled removing electronics, hydration, avoiding triggers, sleepovers, and so we usually truncate them so they go up to a certain point and then come home. And finally, energy. And exercise helps increase mitochondrial function, so keeping active is very important. And so I can't emphasize these as well. So what about CVS and migraines? And I include you in, we think this is very important, and there's lots of literature to show a connection, and we use a lot of migraine literature in our guidelines review of the literature. And at least 80% of pediatric CVS is, in fact, migraine related. So we had 16 questions that we had to address, and the only one that came out with a strong recommendation was the use of anti-migraine agents to try to abort the episode. And that includes NSAIDs like ibuprofen and triptans, such as sumatriptan. The rest came out as suggestions, which is a weaker recommendation. So for acute therapy, again, we emphasize non-pharmacologic, behavioral, trigger avoidance, stress management, psychological, and then we just talked about the use of triptans and NSAIDs. NK1 receptors you may or may not have heard, and the main problem is they're expensive, but there's both an oral and IV form, and if you can get the oral form within 30 minutes before the vomiting starts, it has a high rate of stopping the episode, aborting it. Ondansetron we've used now for 30 years intensively, and unfortunately we don't find it that effective, but it's still a mainstay. And early presentation I'm going to talk about. So this is a paper from Nationwide Children's. I wrote an editorial on this, and he looked at 209 children. A quarter of them each had about 3 ED visits, and of those, 62% were hospitalized. And so how do you circumvent that? And they tended to be boys, younger age, but a 24-hour delay from episode onset to ED visit was predictive of hospitalization, and a longer interval between the visit to being given the antiemetic intravenously, even I estimate by an hour, was enough to predict admission significantly. So he establishes that earlier intervention is associated with avoidance of hospitalization. So it's an actionable item. obviously a written plan with earlier intervention, so once they hit the ER, to get the IV in right away, just put them in a dark room, could prevent hospitalization. But it's hard to do, and we'll address that at the end. Recommendations for preventative therapy, trigger avoidance. Riboflavin had some certainty, and I talked to one family who visited our centers on riboflavin and magnesium with success. CoQ10 is another one, a mitochondrial supplement, and because they're expensive, we recommend a trial, and if you don't notice any effect, and I will tell you, interestingly, I've had the experience, particularly with the limited stamina, that after about 3 to 4 months, I've had some kids just change their activity dramatically, and the parents and the kid just coming and beaming and saying, I can do things like my friends. For preventative therapy, these are the standards that we've used for quite a while. I think what is new is that a prepotent, if you can get prior authorization, may be one of the most effective of this group. Amitriptyline, which has been used, and I've used it by the buckets, we have put a little bit on the back burner after looking at the side effect profile and looking at some of the potential concerns with it. So, for example, in one study, 50% had side effects and 20% stopped it. That's a high, and it's even worse for anticonvulsants like topiramate. And so we recommend they be reserved for more refractory CVS. So this is something new, and it's based on the involvement of the vagus. How do you modulate the vagus if the vagus can't calm the system down? And so Katya, my mentee, who's up in Milwaukee carrying on my work, and it looks like a little hearing aid. You wear it for 5 days, 6 weeks in a row, and you can see, again, the episodes. It's not actually the episodes, it's episode duration times frequency. That score declines, and it actually improves comorbidities, as you can see on the lower right. So this is some of the data kind of in very short. 3/4 reduce their episode frequency, 2/3 the duration, 80% met a criteria for improvement, and the duration was almost 4 months, even though this treatment was 6 weeks. The problem is it's not approved by insurance, although a code is coming in 2026 that will help. Comorbidities at 6 and 12 weeks, abdominal pain reduced at both time points, state anxiety reduced, and sleep improved in the short term, and 100% patient satisfaction. So it's a non-invasive approach with few side effects, and it really seems to have a durable effect up to 4 months. So this looks very complicated, but essentially it divides up CVS into mild and moderate and severe. And so in every one, we recommend non-pharmacological approaches, as we've heard, supplements, maybe neuromodulation, of course, behavioral interventions. And if there are few episodes, they're short, obviously not trying to do too much. If they're moderate, use preventative therapy, and if they're severe, sometimes combination preventative therapy, and or going to some of what we consider the second-line medications. And obviously, the same abortive approaches when they break through. So it looks like this: mild, moderate, severe. Obviously, we do preventative in each case, but that can include medications as it's moderate, and then more draconian therapies when they're severe, and abortive therapies when one needs them. This is called an action plan that one can actually put. I'm going to give you the link to it at the end. Put up on your refrigerator. It's very visual, so when one is doing well, you can see in the green you're taking your maintenance medicines. during the warning phase, then you're thinking, what can we do to abort this? And I think we talked at one point of trying to address anxiety, because anxiety can actually increase the arousal, maybe exceed the threshold and trigger an episode. So calming, and sometimes through medication, sometimes through behavioral techniques. And then emergency room recommendations. So CVS in JDVS, clearly an overlap. And this is the paper, I think it's on many of the tables. And the surprising thing was that it looked like about half were undiagnosed. So if this is representative of a larger cohort, there was only 21 patients. It could be as high as 60%, over half, which is inordinate. So how does JDVS compared? And just to show it, the age of onset, really don't know about that in JDVS, but for pediatric CVS, it's about 5. Adult CVS, which seems to be a different entity, although some do start in childhood, is starting age is 32. It does seem to be different genetically. And the episodes in pediatric CVS are shorter than adult, and in this series, it suggested that JDVS were even shorter. And then you can see lots of admissions, similar triggers, and similar medications. Well, the other thing we've emphasized today in CVS is the comorbidities, and you can see that they're also present in CVS. And from my discussion this morning at the table, a number have a GERD diagnosis, and I will say that CVS, I put an asterisk there because in CVS, many had previously been diagnosed with GERD, and then once they were diagnosed with CVS, then it really realized that GERD was a misdiagnosis. But it could be there because it could represent a motility disorder up top. So it's unclear, and I think I also heard from one family that there may be rumination actually instead of GERD, which can also lead to weight loss and a very underappreciated disorder. So there's still much to learn. So clearly CVS is very common in JDVS, and CVS does resemble CVS. I do think we need more information, and also similar comorbidities, constipation, pain, migraines, anxiety. So I'm going to talk for a couple minutes about GERD and constipation because I heard these were common. Obviously, we do see them in pediatric GI, and I put, again, still an asterisk about the GERD because it's still a question mark. And when we say GERD in the GI world, the D reflux is common. So D means that there are complications such as pain, cough, blood, esophagitis. So in other words, it's not just stuff coming up, but it's actually causing complications. In general, you don't need a lot of testing. So if you present these symptoms to a gastroenterologist, usually the first thing is not to do endoscopy, is just to try treatment. And complete avoidance of tobacco, which even indirect smoke will loosen the lower esophageal sphincter, and caffeine, including sodas and so forth, will do the same thing. And really, the initial treatment is just a PPI, such as proton pump inhibitor, such as omeprazole, for 4 to 8 weeks. And if there's improvement, that can continue, but not forever, because there are complications as well. And if they fail to respond, they can get they should go to a GI person, and that endoscopy can help differentiate a very similar disorder. It's not exactly a food allergy, it's an immune disorder called eosinophilic esophagitis, can be triggered by food and specific foods. And there obviously could be a motor disorder as well, but those are pretty rare. Well, constipation and incontinence, and we've heard certainly a theme today. The definition is fewer than 2 bowel movements per week, and then other qualities include large or hard stools, painful stools, an accident a week, withholding behavior where they're squatting and often looks like they're going, but they're actually tightening their sphincter. So they're unfortunately pushing it back up. And at least 2 of these symptoms for at least 2 months, including the infrequency. So the testing is possibly a digital exam. We do not recommend x-rays, and a lot of doctors will do that and say you have stool, but the correlation is extremely poor. But think about celiac disease, which can cause constipation, and a complication is urinary problems, and urinalysis can help. So the treatment, the key is removing the impaction, because even any strong maintenance will not overcome an impaction. That has to be removed to shrink the size of the distal colon, and then maintenance medicines will work. The main line is polyethylene glycol 3350, which is, of course, Miralax. There are cheaper generics, dietary changes, fluids being the important one, and sitting behavior after meals, which is really important and maybe harder with this group. And if things don't improve, there are other medications. You may have heard of them, linaclotide and prucalopride and so forth. Most of them have not shown much effect in kids except linaclotide. And if you go in, usually what will happen is an anal manometry, but that really answers only one question, not the whole motility, but do they have Hirschsprungs, which is a surgical issue with the lack of nerves just at the rectum. But if there's a more generalized pumping problem, it takes something like a colonic manometry, which is a very involved test. And usually before that, we do a bead study. So you swallow the beads and you take an x-ray at 72 hours, and you see where, if they're hung up, and that may tell you that there is indeed a problem, because there's one called slow transit constipation, where the beads all get hung up on the right side and they don't get to the low side, and that is a warning sign that you may have a much more severe motility disorder. So fecal impaction looks like this, and you would want to do, I'm going to just show this if you want to take a picture, disimpaction. This gives you an idea of the dosing in your favorite sports beverage. And then, and you may have to give it up to 6 days to really get everything out till it's a clear return with minimal particulate matter, and then a daily amount of PEG. And there was concern that there were some toxicities that's been looked at very carefully, and does not seem to have any formation of ethylene glycol. Toilet sitting, and then if things go well, tapering. But in this group, it seems like it's a very common chronic problem. So just as a reminder, on toilet sitting, the target should be 5 to 10 minutes after meals. After meals, you have a gastrocolic reflex. So stretching the stomach sends a signal to the colon to start pumping. And that's, I say, we should ride the wave. And so the key thing is to have the kids, the toddler especially, feet planted on something solid so they can push. And oftentimes we don't do that. What about stimulant laxatives? Absolutely, in this group it may be needed. And here are 2. Again, you can take a picture of senna or bisacodyl, which can be given at bedtime. And then, of course, targeting towards a morning bowel movement. And if bowel movement is in the morning, obviously the child is much more likely to be free during the day, especially at school, really important. So lastly, before the Q&A, want to talk about how to advocate. And here's an example of an emergency protocol. Oh, unfortunately, I had a whole bunch of brochures I'm going to have to give to Cara from the CVSA, and that has a little bit of a protocol. I left them up. A dark, quiet room with minimal vitals, that's really important, because as we've heard, your kids and CVS kids are very, very hypersensitive, and especially during episodes. So sometimes turning on the light, the TV, speaking to them, touching them will set them off into waves of nausea and then vomiting. IV fluids, sooner the better. Antiemetic, ondansetron is the gold standard, but fosaprepitant, which is the IV form, is actually better. And there's not really good research on acute treatment. There's almost no research, but our clinical impression is it's much more effective if you can get a hold of it. Analgesics, obviously we avoid opioids, we use ketorolac, and then sedation, we start with Benadryl, and then we advance to lorazepam. So obviously I'm advocating for earlier intervention, but the echo that I hear from so many of our CVSA support groups is, I struggle every time we go in. We hate to go in. We don't want to go in anymore, and I totally understand that. And we have evidence. We published a series, this is 15 years ago, but 90% it wasn't even recognized. And so you go in, they say, well, we don't know what this is, and then we're not sure how to treat. That really doesn't help. But obviously, at that point, there was a total lack of evidence. There's delay in the waiting room. There's a delay in initiating treatment, and they may not follow the written protocol. Even in my hospital, they didn't want to follow my protocol on one patient, and they may be resistant to your suggestions. This worked really well. I'm not doing that. So, and your child may be subject to repeat testing and procedures, more radiation, abdominal CT, even surgery. Gallbladders are taken out, appendices are taken out unnecessarily, and in some adult series, up to 20 to 30% have had surgical procedures because of these CVS episodes, so beware. And if cannabis has been used, even therapeutically, because cannabis in low dose seems to attenuate nausea and vomiting. In the high recreational dose, like 5 times, 6 times a week, every day for 2 to 6 years, it can backfire and trigger a CVS-like episode. So it seems to have what we call a biphasic, low dose, a helpful, and high dose, it backfires. So advocating now becomes your vocation. So I will tell you, as of today, you know more than 99% of the docs about CVS. But what I usually say is don't use it as a club, because all the doctors are beleaguered. They have to know hundreds of diseases, and then you come and say, I know more than you. This is a problem, you know. So what you want to do is obviously develop a partnership, and it can be with a geneticist, family physician, pediatrician, gastroenterologist, but one with the right attitude who will listen to you, stick with you, and is willing to learn. And it doesn't have to be any specific subspecialty or specialty. Do bring your observations, what has worked, and of course bring your protocol and background. And one of the unique things I advocate for you is particularly when you have struggled repeatedly with the same emergency room, is take your child and the protocol written and visit the head nurse when the child is well, and try to develop a channel of communication, a realization of what our child looks like when they're healthy, that they're quite normal, and say, you know, let's work together. So in conclusion, CVS is a severe debilitating episodic disorder, and unfortunately affects you and your child when the child is so-called well. And I'm certainly hearing that echoed today. CVS has various subtypes, and we, except for the catamenial one, we treat with hormones. We treat with low estrogen birth control pills to blunt the estrogen drop, or Depo-Provera. But other than that, it's hard to say what exactly works in which subtype. In the ones that have very long, predictable episodes, we're using a prepitant right before. So that's one that can be given orally right beforehand, starting maybe 2 days before you anticipate it happening. But the other ones, we're still trying to find out how we can treat each subgroup. And we know now it's associated with JDVS. We clearly need more information, and the doctors talked about that this morning. Certainly the CVS treatment protocols, which I will distribute through CARA, should be trialed in JDVS. So that's all, folks. Thank you.
Thank you very much. Hello there. You mentioned the vagus nerve a couple of times.
Yes.
And it's been suggested to us, mainly by Dr. Google, that resetting of the vagus nerve could help offset an episode. And that would include jumping into a hot shower followed by a cold shower, or blowing into a vagal maneuver, blowing into a small diameter tube. Are they realistic? Could there be something in them?
So you mean other ways to affect the vagus other than this?
Yes. For a non-compliant child who's about to have an episode who doesn't want to do anything.
A great question. In migraines, they are using kind of percutaneous, hitting the vagus here with a stimulator. I can't say I know too much about that, but I will tell you one of the unique experience I've had that kind of led to this approach is that we had several severe seizure patients, and they put in an inserted vagal stimulator and to control the seizures that didn't respond to medication. And they also had CVS. And as they cranked it up, the seizures got better, the CVS went away. And so we got this idea that vagal modulation would be better. But the migraine people have been doing that sometimes, not using the ear, but using another approach temporarily right at the onset. So could blowing in, I don't know if that would work. It might not be potent enough.
Hot showers suggested to us as well, and you also mentioned earlier on how...
The hot showers probably don't work through the vagus. The other thing that they use in the cannabinoid hyperemia syndrome is capsaicin. Capsaicin is hot chili oil, and they rub it on the abdomen. Both capsaicin and hot showers trigger a receptor called TRPV1, which modulates pain. But when you do it in high dose, it actually looks like it can act as an antiemetic and or trigger the cannabinoid, which in the positive way that calms down the anxiety and the vomiting. So it's unclear, but hot water up to about 43 degrees, which is 104 or something Fahrenheit, will activate this TRPV1 cascade. So it doesn't seem to be the vagus, it seems to be something else. So it's something, obviously hot water is something you could try definitely at home and see if it helps. And we don't know, there have been no studies using capsaicin in CVS. It's widely used in the emergency room for CHS, the cannabinoid, that they will rub this hot chili oil.
Hi, I just want to say that I personally went out to Children's in Milwaukee and met with Dr. Kovacek or Corrento
Yes.
a few years back.
Yes.
You are a true legend there. They still refer to it as your clinic a lot, and she's running it. But anyways, I had first came into the experience with severe cyclic vomiting probably shortly before our son, Noah, who's now 5, was just before 1. However, kind of in that limbo of, is this just more spit up and different things like that. But then it completely progressed over the time of turning 12 to 18 months to the point of being completely debilitating for him and for us.
The spitting or the vomiting?
The true vomiting. The amount of hours we spent in the shower with him and with vomit on us, and him completely unable to retain anything, like you said, the retching, and all of those symptoms for a long period of time were just completely overwhelming for our family. Still, what I would consider one of our biggest symptoms that we've had. So at that time, I didn't really know what to do, and so I started Googling and came across Dr. Kovacek, and I found an article she had been published in, and somehow found a link to her email and kind of stalked her and said, hey, I'm from a different state, but we're really struggling here, and no doctors that we've talked to know how to manage this. So I asked her if she would be willing to see us. We eventually traveled from South Dakota then to Wisconsin. She accepted us as long as our pediatrician would follow her policy. But prior to doing that, I had tried a lot of medications, primarily because I'm in anesthesia, and we do so many medications for postoperative nausea and vomiting, many of the ones that you had mentioned. So one of the first drugs, of course, we did was Zofran. We did Benadryl. We had oral and rectal Phenergan. We had Decadron. I don't know if I had mentioned that. And none of them would completely take care of the symptoms. But since I had worked in the OR and I had worked with a lot of different medications, I begged our pediatrician to let us try Emend, or which is the aprepitant that you're talking about, because it's so successful in the OR comparatively to other medications that we give for PONV. But to get that compounded dose for him at 12 to 18 months was 3 doses, I believe, like 1.2, 1.8, and 1.2 or something like that, and was probably like $370. And of course, insurance didn't want to approve it. We eventually fought that battle, and now Noah takes Emend Monday, Wednesday, Friday, in addition to the CoQ10, the cyproheptadine, Spectrum needs for the supplement, and we do a probiotic called Neurali, which is aimed at ADHD and autism and different things with that. And he has probably had less than 2 episodes per year almost since that combination started.
And before, how many were you?
I can't even tell you how
More
many.
than once a month?
Oh, yeah.
Oh,
Sometimes they would be almost back to back,
Yes.
and we got into a really tough point where we were almost in it for 2 to 3 months at a time.
Yes. I would say, obviously, very difficult situation that even in toddlers with that difficult case in the past, I would have used amitriptyline, which we don't like to use in that young. But today, I would use aprepitant, and there is a protocol for using it twice a week preventatively. It's usually used to prevent or abort the episode right as the child's going in, but they also studied it using it twice a week, and it was preventative. And if it doesn't work, then we would go to 3 times a week, and that's kind of the quote, the max. And I'm glad that that's worked, because you definitely are following what is really, really current.
She did make us a protocol, which I thought was incredibly helpful. That was one that was on there, like if we continued to decline, and then also the guidelines for either emergency room admission versus actually being fully admitted. And so now that's a permanent part of his chart. But like you said, whether or not they follow it, I think I'd probably push pretty hard to make them do it.
Yes. And
There-
you did a great job of advocacy, I will telling you, and stalking, I will. So even if you're arrested,
watch
you
out.
did the right thing.
I'm coming after you. The one medication or a couple thoughts I had, just kind of stemming from my background, is there's a medication that they're talking about because a lot of the medications like Zofran, all of those are more considered to be preventative,
Yeah.
right? But there's not a lot of rescue meds. But one has been presented to us in anesthesia. We haven't fully accepted it yet, but it's called Barhemsys or Amisulpride. That one is thought to be a rescue medication. So they're trying to encourage that for us, for those patients that do have some of those medications in the OR, but now have made it to PACU and are in an event, we are having a hard time aborting it. Because for people just that have normal PONV, it can be hard to stop. So I didn't know if that's something that's been considered as a
Don't
medication.
have any experience. The one thing, I did mention sedation, and this is kind of an accidental observation that I probably had 3 patients that had big-time sedation, propofol, et cetera, for a procedure, something incidental, and they woke up and the episode was over. So there is one protocol, it's an ICU protocol using dexmedetomidine.
Yes, Precedex.
Yes, and the problem is you have to be in an ICU in a pediatric ward. You can't do it on a regular ward, so it's big expense. You don't have to intubate. It seems to be quite safe. In one patient, we probably did it about 14 times, and basically what you're doing is shutting everything down. It's almost like rebooting a computer, that you shut everything down, and what is just, this storm that's going on, you just quiet everything down, and then you let them come up, and the episode is over. But, that's kind of extreme.
Yeah.
Yeah.
No, I actually think that kind of spurs my next question, as you were talking about how it mimics CRPS, or the complex regional pain syndrome. And another thing that I've seen used a lot in our area for CRPS or PTSD, anxiety, different things like that, is the new trend, I guess, to do something like a ketamine infusion clinic. And if there's any discussion on whether that would be something that is helpful or not in these individuals.
Don't know. Very interesting. Yeah, it's a very interesting idea. I'd like to hear more from you.
Okay. I think I'll try and turn off my questions now so somebody else can talk.
Other questions for Dr. Lee?
We had an interesting experience once where Wells was able to verbalize. There had been a light that was flashing where he was sleeping, and he woke up and just started vomiting, and then later on in the hospital, he verbalized that it was the light that had caused it. Is that common?
I wonder if it was an aura. Do you think if he wasn't asleep, I just wonder if he was seeing lights.
No, it's a long story. It was an alarm clock that lights slowly, but 2 alarm clocks had been set, so it was 2 colors going back and forth. And he was absolutely very clear and very certain that is what had made him sick. And after that, he's a little bit anxious when there are flashing lights like that.
Migraines are often stimulated by vertical, I think it's vertical or horizontal, I think it's vertical blinds, so there is some sort of light pattern that will trigger migraines. I think it's very possible. I haven't heard that specific thing, but.
I was going to mention the thoughts on the deep sedation too, and just what I've kind of thought about it, just because I do take care of these patients under anesthesia. And so I do think, propofol is a known antiemetic, but I also think because in combination of any time we do a general anesthetic, especially for a kid, I am always going to give them propofol, Decadron, Zofran, and likely some fentanyl if it's a pain-stimulating procedure. But I have found with Noah, even when he's had to have maybe a general anesthetic for MRI where they need him to be very, very still, that some of his symptoms and other things improved after that sedation. I think that the Decadron was also very helpful because there's been times where he's maybe had a little bit of what I would call a neurodegeneration, like where he's been very, very verbal and all of a sudden he regresses and is having some stuttering or something like that. He goes in and has that general anesthetic, and when he comes out, he's not doing the stuttering anymore. So I do think that that does play into some of that neuroinflammatory model, but I do think that the element of like giving them Versed is also very, very helpful because that anxiety component. So I think it's kind of that whole model of the multimodal meds that they're getting that's giving them that relief.
Fascinating.